Okay, hello everyone. My name is Dr. Henry Pollard, and we'll be chatting with Dr. Martha Funabashi from Canada. I'm here in Sydney, Australia on a fairly gloomy morning. Hopefully it's a little better where you are. But Martha's research has struck my eye recently as something that is something of an area that's not spoken too much about outside of the spinal areas, and I'll come to that in a minute. But probably it's appropriate that we introduce you to Martha at this point. So Martha is a clinical research scientist and assistant professor at Canadian Memorial College of Chiropractic, and an adjunct professor at I think they refer to that as the Three Rivers Chiropractic program as well. She has a bachelor's degree in physiotherapy, a master's degree in neurosciences, and a PhD in rehabilitation sciences. She did her postdoctoral fellowship in patient safety and is also a senior Carl fellow. Martha's research interests and passion include biomechanics, and particularly the underlying mechanisms and safety of manual therapies, and their focus on spinal manipulative therapy and spinal mobilizations. So it's a very relevant research project, and I think particularly relevant, as you'll hear shortly, for sports chiropractors around the world. So the study itself is a Delphi study aimed to determine by an expert consensus process standardized definitions and severity classifications for adverse events following spinal and peripheral joint manipulation and mobilizations. And the bit here that kind of caught my eye was the peripheral joint manipulation and mobilizations. Professor Cassidy, also from Canada, has presented a great amount of work on adverse events and dispelling common misbeliefs about the role of manipulation in vertebral basilar insufficiency and other related syndromes. And I believe that this study goes a little further and incorporates extremity joint involvement with manipulation and what potential adverse events. The whole point of all of this, of course, is to promote safety with the patient base and to avoid procedures that are unnecessarily risky. So with all of that background, I would like to introduce you back to Dr. Funabashi, and she can give us a little bit of a chat about what she's been up to. So perhaps a little bit of a background about yourself, if you want to add anything further, and then how you came to be studying this topic.
Thank you. And well, first of all, thank you very much for the invitation to be here today. It's my pleasure to be talking to you all. So in terms of background, I think you covered it all. I have a physiotherapy degree, and while I was doing my master's, I was also receiving some training on osteopathic techniques, and I was also practicing in a rehabilitation clinic that is all back in Brazil, where I'm originally from. And it was in that scenario that I got interested in research and how manipulation works, because I started to apply those techniques to my patients, and some of them were getting better and some were very chronic. We tried a lot of approaches with not a lot of success, but then they responded really well to manipulation. So that's how I got interested in going back to research and learning more about how it works. But as we all know, whenever we are choosing a technique or an intervention to treat a patient, we have to consider not only how the benefits that it can bring to the patient, but also the potential adverse events or potential risks that it can be caused to the patient as well. And it was during my postdoc that you mentioned that it was with patient safety, and more specifically with the safety net project, that we were looking specifically at adverse events following chiropractic and physiotherapy interventions, that it kind of sparkled my interest in how I personally haven't thought about that um, very much, including when I was in clinic. So, and follow the postdoctoral fellowship kind of followed my PhD, which was specifically focused on biomechanics and biomechanics of spinal manipulation. So I think it just made sense to kind of combine both and try to look at some like some bio at safety, but in a biomechanical perspective. However,
Was that, sorry, was that where the connection between the physiotherapy background and a little bit of osteopathic involvement there, and then the connection through to the chiropractic came through at that level, and perhaps supervision? Just where did that connection come from? Because I know that back in Brazil, there's been some schism, to put it mildly, between the groups, and I love the fact that we can all come together and investigate and be involved with similar procedures for the benefit of all. So yeah, so how did that connection come about?
yeah, that's a great question. And I think it was because of my PhD supervisor, which was
Yes.
Greg Kotchak. So
Oh, there you go.
so he kind of introduced me to the chiro world. Personally, I never saw anything like physio world or chiro world or
Yeah,
osteopathic. For me, it's just kind of everybody under the same manual therapy umbrella,
that's
and
the
I
world.
see yeah, exactly. And I see our research as being focused on the technique rather than a specific profession. And I
Yeah,
think that's one of the beauties of these specific project, because we're going beyond any specific profession, and we're since we are focusing on the technique itself, both manipulation and mobilizations, we are just involving everybody. And by making everybody and all representatives from every single profession and every single continent of the world, I think we are trying to get everybody on the same page of what is an adverse event, so that we can learn from each other, right? And we
yeah.
can, uh, regardless of profession, just focusing on what is best for our patients.
Absolutely important. Kudos for doing that too. Now, just on the classification systems, all right. So you've mentioned the mobilizations as well as the manips. So are we talking about Maitland grading systems with or without HVLA intention? So how are you classifying the mobs versus manips? Just because as you know, that some of those definitions, particularly in the manipulation sort of end of things, are a little different between professions. So how are you handling that?
Yeah, that's a great question. And for us, manipulation involves the high velocity, low amplitude force application, and mobilization would be low velocity and variable amplitude force application as well. We are not adhering to any specific grading system like the Maitland
Mm-hmm.
grading, but just having that overall definition for both techniques, I think we are being able to capture most of the techniques the manual therapists are using.
Yeah, excellent. Because yeah, certainly from my point of view, I've always thought of that as just the intent of the procedure is really where the difference lies. Because if the intent is a manipulation, if you don't get the crack, it's by definition a mobilization. But is it really? So I think it's a nice pragmatic way to look at it. Now, if we're talking about pragmatic, now could you perhaps getting into the study specifically now a little bit more so? Just could you describe the Delphi process that you're going through for those that may not be familiar with what that's all about?
Yeah, for sure. So the Delphi process, it recruits experts in any specific topic, and for us is um, manual therapists or people related to either manual therapy or specifically manipulation and mobilization, and or patient safety or adverse events. So and because this is looking at determining a definition, a standardized definition and severity classification for adverse events. We are including researchers that have a strong interest in that topic, clinicians as well, but we are expanding that in recruiting also patients, students, and even beyond that, regulatory body representatives, insurance practice representatives, and we even have lawyers, medical doctors, and data analysts. So we are going uh, beyond, so that in our results, like the consensus, the definition we end up with, it's accepted and had input from all of these groups that somehow have an interest and are somehow involved with adverse events and patient safety related to manipulation and mobilization.
Yeah, I see that this has real implications for setting standards on definitions. I've sort of suggested for a long time that most of the problems with the adverse events, particularly the major ones that we keep hearing about, even though they're very infrequent, have got more to do with misdiagnoses than they have to do with actual improper application of technique. So it'll be curious to see how that all kind of comes to play so far. So anyway, you're in the process. You've just started stage 2. So perhaps you could just outline what the various stages are and where you're at and where you plan to go.
Yeah, perfect. So right now, so this Delphi, we have 3 rounds of questionnaires planned. As you mentioned, we are done with round 1, and round 1 was pretty much open-ended questions because we wanted to get a sense of what participants think when we say define adverse events. Kind of, we didn't want to lead them anyway. We just wanted to get a sense of the general idea from everybody. And it's in total we had over 200 people signing up for this study. Round 1 had almost like 200. We had 180 people responding and providing their definition, their own definitions. We went through a very rigorous qualitative analysis of each and every single response. And based on that analysis, we came up with the questionnaire for round 2, which is live right now. So it includes terms and potential combination of terms that were derived from that qualitative analysis from participants' responses, as well as last year we did a scoping review to see what is out there in the literature in terms of definitions and classification. So for round 2, we are combining what we found in the literature as well as what participants told us. And then from these questionnaires, I think we are hoping to get people kind of coming together in a sense of what they think an adverse event is and agreeing on the wording and the terms to be used. So once round 2 is complete, then a few weeks later will be round 3, and that hopefully is the final round where we can propose a few definitions and then get a consensus on a one standardized definition to be used as we move on.
Okay, thank you. And with regard to the adverse events, how are you grouping those for spine and for extremity? Because they're potentially quite different. And over what timeframes too? One of the contentious points has often been you'll see things written up inappropriately, I might add, that there's been a reaction that has occurred 1 month after somebody has received an intervention, and that's sort of stretching the bounds of credibility. So how's your group handling all of that?
Yeah, that's a great question. And from both literature and round 1 responses, there was not a lot of people saying that adverse events should be defined differently from between spine and extremities. So, and actually they're not even, not a lot of people saying that actually it should have a different definition from what is adverse event in healthcare overall, which makes sense, right? Because manual therapies are part of healthcare, so the language has to be somewhat comparable. But in terms of, I'm sorry, what was the second part of your question?
This part was more about the sort of the timeline for the adverse events and how they might be described.
Yes, and that is very interesting because the duration of adverse events was like how long the adverse event lasts is something that came up during the round one questionnaire as well as from the literature. However, the time of onset was not so evident. So it's interesting that you mentioned that because not a lot of people thought about that when they were responding round one. There are a few studies that did include that in the literature, but not a lot in the responses.
Okay, that's interesting. And so far through the process, what would you say you found that had been a little more challenging than other things? That
That's a really great question. I Well, being a biomechanist, my brain is very much quantitative. So going through the qualitative analysis of 180 responses within the time frame that we had was a little bit of a challenge. Not so not only because we were looking at definitions, but also at severity classification. So at some point, our brain had to shift from the codes we had developed for definition to the codes to developing new codes whenever we were coding the severity classification, and I think just trying to summarize all those responses and trying to combine them or trying to combine them in a way that it's somewhat staying true as much as we could to the participants' responses, and even trying to keep their own words, but at the same time, kind of merging them in a sense and summarize. That was very, very challenging. It was very interesting. I learned a lot, and it was a lot of fun, but very challenging.
maybe a little technical of this question, but obviously you could get 5 people in the room and get 5 potentially different responses on what they considered important with any particular data set. So how did you get around the issue of reliability in selecting these issues?
Yeah, that's one of the greatest challenges, right? And I think that's why we went with a qualitative analysis, because then we didn't have to necessarily stick with with the specific wording, but we could get a sense of what they meant with their response, and get a sense, oh, this person meant this and this person meant this, and even though they used different words, they were somehow meaning the same thing, or as much as we could. And some responses were completely off. So that's why we have this whole process of going through other rounds of questionnaires, so we can first make sure that we are not interpreting too much. So in round two, you will see some questions that we are trying to better understand what participants meant when they use certain words, when they use certain terms. So we do ask for their feedback on that, their thoughts or more guidance on that. Um, and um, and yeah, I think that was the process. And the whole time, we had an expert in qualitative analysis, just making sure that the process was still being rigorous, despite of my lack of experience with qualitative analysis. Like, we had someone making sure that everything made sense, and it was.
So more than one set of eyes was assisting the selection process on what was important and what was not.
Absolutely, yes. Besides me, there was another one that so we had two investigators coding, developing qualitative codes independently, and then we would get together with a third, with the qualitative expert, kind of to discuss, refine the code, getting to a consensus, and make sure that we were on the right track. Yeah.
Great. That was what I was after. Good. Thanks for that. Now, all right. So you're sort of 2/3 of the way, or maybe half of the way through. So how do you see the project going from here? What are your kind of your milestones and your goals from this point forward? And when do you think you might get to the other end of this process?
Yeah, so hopefully, like with the next two rounds, we can keep a good response rate, because that's always the challenge, right? With surveys and multiple surveys in the same study, the response rate coming down is always a challenge, and we are trying our best to prevent that from happening. So hopefully, we can get a good response rate as good as round one, if not better. Second thing is that every time a round is completed and we have to develop the next round, it's always a time crunch on our end, right? So we can analyze everything and put the next questionnaire together, and then release it within the time frame that we already told participants, so they can keep planned, so they can plan themselves, right, and get organized. Hopefully all the rounds will be, and I'm just looking at my calendar here right now, and hopefully all the third round will be completed by end of June. So
Okay,
we'll
soon.
be conducting the analysis during the summer, well, during Canadian summer, so July and August, and hopefully it won't be too long until the manuscript is submitted. So hopefully by the end of the year, or maybe beginning of next year, you will have some publications already, hopefully.
Excellent. Well, thank you very much for outlining that important study. We wish you all the best of luck with maintaining what is already a very good response rate. And so hopefully you can hang on to that as you move forward. Were there any concluding remarks you'd like to add?
No, just thank you for having me here, and thank you for everyone who is participating or who will be looking out for our results whenever those come. Yeah, and thank you very much.